I'm Dr. Patrick Kinda, orthopedic surgeon and chief medical officer at St. John Paul II Orthopedic Mission Hospital. And I'm doing a fellowship program in African Trauma Initiative with Dr. Eddings. That's why I'm here in Kansas right now. And today I'm going to talk about trauma epidemic in Africa. Okay, talking about trauma in Africa, musculoskeletal trauma conditions are the most common cause of severe physical disability and death worldwide. Injuries make up a significant component of trauma globally, accounting to roughly the same number of deaths each year as HIV, tuberculosis, and malaria combined. That is according to WHO study done in 2018. Injuries also means this trauma, they require also a substantial burden of global public health resources, as they are the leading cause of death among young adults aged 15 to 29 years. And Africa in particular is a continent that experiences a large burden of trauma and the highest concentration of trauma worldwide. In the world outside of Africa race to profit of Africa resources, and out of Africa own race to rapidly industrialize to improve the quality of life of those in the continent, no one has substantially invested in the healthcare system needed to treat this injury that are occurring as a result of this rapid industrialization. Road traffic accidents, construction and industrial accident, interpersonal violence, which include war and conflict, folk and natural calamities like earthquake and others are causes of trauma in Africa. And road traffic accident is considered to be the main one. Nearly 90% of the world's road traffic fatalities occurs in low and middle income countries, and half of those dying from road traffic accidents are vulnerable road users, such as pedestrians, cyclists, motorcyclists. And the road traffic accident injury has been neglected from the global health agenda for many years, despite being predictable and largely preventable. On the next slide, there is this picture I've put there. And as you can see, this is common things which we see when we're in low and middle income countries. You can see that these people travel on top of this train, means inside is fully packed. And by putting this picture, I will just tell you a short briefing of my history. I was born in Katanga province, which is part of DR Congo, and I grew up there. I did my primary school, my secondary school there, half of my secondary school, and it was in a hospital. It was a well-organized province, and with good school, good hospital, and everything was going well. But just halfway my secondary school, when the democracy came, because came in my country, that is in 1990 to 1994, suddenly there's this politic issue which make me know that I'm not belonging to that province. Now there was this war, this conflict in between people originally from the Katanga province and us. We were not actually from there, but I was born there. My parents, they were born there. And for me, I was from that province. But definitely when that conflict came, now a lot of people like me supposed to travel from the Katanga province and to go to the center of the DR Congo, which is a Kasai, which I've never been there. My parents, they barely know that place. But it was said that is our place and where we need to go. Now, a lot of people, they were traveling in this condition. And the way from the Katanga, from the Kasai province, in a normal time, it can take only 3 to 5 days of traveling. But there are some people who made more months, 3 months, 6 months in the road, just from living there and reaching at the place where also they are not going to be welcome. A lot of them, they died because of this condition of traveling. Why this picture it's a reminder for me, because there's one time, the time I was in the Kasai province, I traveled also in the same way, because I was at this train station waiting for the train to come. But when it came, when I went inside, I noticed that there were no space for me sitting, even putting my legs. Okay, I traveled like that from one station to another one, but because it was very uncomfortable, because I was supposed to travel from 2 p.m. to 6 a.m. the next day. And definitely on the next station, I came out and I saw that people on top of the train, they were very comfortable. And I decided also to go there. And I traveled like that until I reached my destination. But believe me, there are too many accidents in this way of traveling, too many casualties. And people who are traveling like this, those are the people who first, they are poor, they don't have money and everything. Means even make it to the hospital, make it for surgery, that is another dream. Okay, now, when reaching the province where I was told that's my province where I'm originally from, now it's a battle, because you have to battle to survive, okay? You have to battle how to go to school, how to make it just to make, to be able to eat, to have meal for the day. Now, a lot of young people, they find themselves working in mines, okay? Because that side we found there is too much like diamond and all of it. And there's this type of artisanal mines where youth were working in with very miserable salary and everything, but that was the way to survive. And you can imagine that working in this condition, there are a lot of who died, they lost their life. A lot of them were injured because it's very unsafe. We can go to the next slide. I will show you what has happened, because on the next slide, you can see that they have to go underground to check for, to get to what they are looking for, which is especially they're working in diamonds mines. And you can see that they don't have anything which protect them, like to have all the safety protection which a miner needs to wear to go down there. And these are artisanal mines that can collapse at any time, and there are a lot of them who remain buried down there, and maybe no one will never come for them. Or when you come, you are able to come out, a lot of them, they are injured. And as I said, without good trauma center, it's actually difficult to make it through surgery. A lot of them, they are trader, and that's what they do. Okay, means when you are traveling inside the country, okay, inside the country, in the big city you can have good roads, but when you are going inside, in the rural area, that's the way people travel. Okay, traders, exactly. And you can see that this is a risk. Anything can happen, and definitely you are going to have casualty there, and to fix them, it's a big challenge. We can go to the next slide. That is what happened actually in the rural area, because in the rural area there are no roads, there are no good roads. Means a trip which you can make in 4 hours, that can take you days. And there are too many accidents. I lost 2 of my friends, which are medical doctor in such trip. And actually almost every day we have casualty in such road. And the next slide is also showing the same. The next slide is just showing also how the traffic is there. And definitely when you look at this, nothing good can come out of such traffic. On the next slide, you can see that I spoke about in my introduction about there's rapid industrialization in Africa. Means there are big companies which are there, and these are trucks by the border in between Congo and Zambia. Actually, they are coming from Congo, and they are packed with copper and other minerals and everything. There are a lot of companies there, but the health system, that's the one which has been neglected. They don't invest in the health system, but every day when you're at the border, this is the situation which you find there. This one also is a border, and that's the same situation. Now, out of those roads you have seen in the rural area, these are big city. You can see that there are good roads there, there are good bridge and everything, but the main things here is to follow the traffic, to respect the traffic. That's the main things there. And when the traffic is not followed, is not respected, everything's moved the way you want. We can go on the next slide. You find a situation like this, where you can see that here we're in the big city. We're in town, actually. You can see there are good roads, but see what happened to that truck, the way it's full of people, and anything can happen at that time, then you will see this, okay? These are common trader. They come usually from a rural area and to do the whatever business in the city, but that's the way usually those trucks, they are packed. And they move like that in town and everything, then everything can happen, then you have too many injuries here, but the main issue is it's going to be very difficult to treat such casualty. That's why I was saying in the beginning that road traffic accident, it's a main cause of trauma in a low and middle income country. Now we can move to the next slide. As just to end up my story, as I say, as we move there, I was just one of the lucky one who managed to make it up, to go at up to my level of university, and to become a surgeon, and to be here today. But as you see, me and Gloria, actually, Gloria is from that province where we had all these conflicts and everything. In a normal world, for me and Gloria to get married, this is it's a taboo. Means it can't happen, and a lot of people they still living in this way. But for us being together like this means is just a way of people who we don't care about those conflicts, and that's a way we can even solve conflict, because when you are together, families can be together and everything, then you understand that we are just same people, and everything which happened, it was just a manipulation from politics, and which was coming from actually high developed country. Then on this slide, and I say evidence from many countries show that dramatic successes in preventing road traffic crashes fatality can be achieved through concerted efforts that involve improvement of the health system. On the next slide, we are going to talk about the trauma burden. As said previously, low and middle income countries faced a majority of the burden from trauma worldwide. Trauma caused substantial economic losses to individuals, their families, and to the nation as a whole. These losses arise from the costs of treatment as well as the loss of productivity for those killed and disabled by the injuries, and family members who need to take time off work or school to care for the injured one. And WHO estimates road traffic crash cost most countries around 3% of the gross domestic product. Zambia acknowledged trauma as a major cause of disability and premature death in 2013-2016 strategic plan on non-communicable disease through very little, which is less than 1% of its national gross domestic product, which was allocated to the health expenditure. Means 9% or $3 per capita in 2018. Moreover, out-of-pocket expenditure make up a significant proportion of trauma costs in the country. And in 2018, the total number of disability due to trauma totaled 504,000, which resulted in $738 million in economic productivity loss, which is about 58% of economic productivity loss were to individual age 15 to 49 years. And when you have such numbers, which is recorded just by the RATSA and by the government, but this is not all, because there are a lot of them, a lot who are not actually recorded. Next slide. As Zambian population is younger in age and growing in size, trauma become an even greater concern for individual and national socio-economic well-being. The population of Zambia is projected to more than double by 2050 and increase 5 times by 2100, making one of the fastest growing countries in the world. Apart from that, Zambia is also experiencing rapid urbanization, with 44% of people living in urban area in 2020 and projected to increase to 50% by 2035. And that will increase exposure to high-risk environment for trauma, with the negative impact of early stage of economic improvement characterized by unhealthy lifestyle, increasing prevalence of unsafe transportation, excessive intake alcohol, and unsafe work environment. Next slide. In addition, the geopolitical situation of Zambia and in Southern Africa make the country extremely vulnerable to political and societal change. This risk factor drives a high burden of injury, affecting young Zambian. Okay, we are going to talk rapidly about trauma reconstruction. Here I just said the healthcare system in many African nations are not optimized to treat trauma. And we can see that, number one, there's need of viable infrastructure and orthopedic equipment. There's a study which was conducted by COSEXA, which is a college of surgeons in East, Central, and Southern Africa. And this study was conducted in 10 countries, which are part of the COSEXA region. And the study was, the data were collected in the 267 hospitals, including 185 district hospital and 82 referral hospital. And what came out of the study on the next slide, former accident and emergency department were present in 21% of hospital. 90% of the hospital had at least one operating room, but functioning C-arm, which is the X-ray we use in surgery, C-arm and X-ray machine were available in only 4% of district and 27% of referral hospital. And when you are an orthopedic surgeon, without C-arm, you can't do anything. Or if you don't have X-ray in the hospital, then you can't diagnose a fracture, you can't do anything. You're completely stuck. Adequate instruments for surgical treatment of fracture were found only in 20% of districts and 49% of referral hospital. And more than half of the referral hospital had one-third of the district hospital had a rehabilitation unit of patient. And without a rehabilitation unit, also you can do a good surgery, but without a rehabilitation unit, then your surgery can fail. Means rehabilitation and orthopedic surgery, they go together. And few facilities add limb prosthesis and manufacturing. On the next slide, this is operating room, which I use in Lusaka. This is operating I use in Lusaka with a table there, which is also a traction table, but the quality is not good. I've seen patients almost falling from this table, and compared to what is done here in KU, on the next slide, you see the operating room in KU. This is a traction table on the operating room. You can see yourself the difference. And when you don't have a good traction table, and your surgery is going to be, when you're operating especially on lower limbs, is going to be very difficult and sometimes unsuccessful. That's the main difference. Just a table can make a big difference in your surgery. Next slide. I'll just show you the C-arm. This is a C-arm, which is X-ray machine we use in theater, which is quite expensive machine, and you don't find it in most of the hospital, even where they are doing orthopedic in Africa. It's difficult to find such machine, and without this one, you can't do a good surgery. And on the next slide, this is my operating traction table in theater in Lusaka, which is does good job, I can say, but I know myself that quality is not good, and you can have a lot of problem with this one compared to, next slide, Alexa, that's the normal traction table, the way it's supposed to be. That's the similar of the traction table which is used in the KU hospital here. Apart from, as I said, we need a good trauma center, there's a need of training opportunities. On the same study conducted by COSEXA, it showed that most hospitals had no general or orthopedic surgeon or medically qualified anesthetists on staff. Closed fracture treatment was offered in 72% of hospitals, although there's deficiency in X-ray machine. I can imagine how they were able to do all those closed hospitals without X-ray. And elective orthopedic surgery was offered in 29%. In many hospitals in Africa, general surgeons do most of the orthopedic work. Generally, in rural area, general surgeon or general practitioner provide care for musculoskeletal injuries, and that clinic coverage by general surgeon is partial. Most care is provided by general practitioner and substantial amounts by nurses and other non-doctor providers. On the next slide, there's a need of patient ability to access trauma and orthopedic services. In some cases, when both equipment and manpower are available, especially in some private hospitals, there's still a big dilemma for patient accessibility to treatment. This is a place where the disadvantage of a poor take a big space. Generally, in several African countries, and particularly in Zambia, quick and good trauma services are provided in private sectors, where well-trained healthcare provider and almost adequate updated equipment are found, but where also patients with low financial income find it difficult and almost impossible to access treatment. In this institution, patient attention is based on insurance coverage or cash payment, which can be fulfilled only by a small minority of the population. Next slide, we see also there's lack of monetary resources to support the needs of local health system. And one of the main reasons there's lack of adequate healthcare system in some low and middle income countries is because of lack of money. Many institutions like where I am self-sustain themselves. I left the hospital. Before I left the hospital, about a year ago, we have our MRI machine which went down. And up to now, that MRI machine is not, because it's supposed to be replaced. Because of the break which is there, we have to replace it. But when you have to pay workers' salaries and to cover for the disabled children, which they don't pay, and you have to pay insurances, it becomes difficult for the hospital to fundraise money to buy a new machine. This is the C-arm I use in my hospital. This C-arm has been there for years. That's the only working C-arm in the hospital. My hospital is one of the main orthopedic center in Zambia, in Lusaka. But we rely on this C-arm. And once this C-arm goes down, we need to replace it, and which require also a lot of money. But with all those challenges, it's quite difficult. Next slide. On the next slide is showing also the monitor of the same C-arm, which is actually an old one. Yes, on the next slide, you can see that we built a new theater at our hospital with 3 operating rooms. But here I showed you first the room which we are using, but this is an empty room, which we don't have enough funds to put equipment in this room. There are 3 rooms because we have a lot of surgery to conduct, but we are able only to use 1 room. There's this one, there's another one next to this one. They are still empty because we need to get money to to put equipment in those rooms. We can go to the next slide. The next slide is showing the same room which is empty. There's only a table. Actually, this table was purchased from the United States, but apart from this table and the good light we have there, there's nothing else. And on the next slide is showing also the third room, which is empty. You can see that we have even put sofas there. Trauma represents a global public health threat which can result to injury to different parts of the body: brain, lungs, heart, intestine, spine, muscle, bones. And the prevalence of injury to these various parts of the body differs substantially, as well as the amount of resources required to treat this injury. Musculoskeletal impairment condition, which is trauma damaging bone and muscle, are the most common cause of severe physical disability and death worldwide, and it accounts for the largest amount of trauma in Africa, it was said before. And Zambia acknowledged trauma as a major cause of disability and premature death, according to the study done in 2013 and 2016. Considering the amount of hospital resources required to efficiently treat these injuries, means length of hospital stay or intensive care stay, musculoskeletal trauma needs often less time compared to brain, heart, lung, or gastrointestinal trauma, and the prognosis is far much better when managed appropriately, allowing the patient to tremendously recover and return to close to pre-injury function, while despite the application of tremendous amount of healthcare resources for trauma involving other systems which save life, but does not come close to restoring pre-injury function. Okay, these are the solutions now. We are going just to talk briefly about the African Trauma Initiative. International Orthopedic Trauma Fellowship, with non-specialists providing much of orthopedic and other trauma surgical care continuing education courses, become an important opportunity to strengthen such care, especially at first level healthcare facilities. If we want to start in a place that is going to have a largest impact on death and disability due to the new epidemic of trauma in Africa, the best place to start is by elevating the care of orthopedic trauma. Next slide. Therefore, through the African Trauma Initiative, the International Orthopedic Trauma Fellowship for practicing surgeons from low to middle income countries is a program which tries to improve knowledge and skills of fellows during the 1-year training at KUMC, and they will return to the countries to pass on this package of knowledge to other surgeons who will be able to perpetuate this in aim to improve better care of patients. And this program includes realistic surgical training, which is we perform on sawbone, on cadaver. There's immersive surgical care participation, which is done in actual operating room. And there's a clinical participation where fellows have to participate at least one clinic day per week, during which we discuss with the whole team about trauma and treatment. On the next slide is just an example of what is done in the lab. This is a sawbone training in the lab. Okay, just is a model of the pelvis, but we start from this one. And okay, on the next slide, that's a cadaver practice also in the lab. Means the same fracture which we saw in the operating room, we try to replicate them on the cadaver, and using the same system, CM equipment and everything, we try to fix that fracture. That's a way of learning we do. And the next slide, it's in actual operating room. Okay, apart from what we do, there's also conference participation. The fellow will participate in orthopedic trauma conference, and there are also national conference and training seminar which are organized. And there's also a research where the fellow will produce at least one research paper where they become a subject matter expert in area of orthopedic trauma. Apart from the from equipment and from fellowship program, there's also building of high standard trauma center, which is also part of the plan of the African Trauma Initiative. We can go to the next slide due to the time. And apart from building trauma center, there's also, next slide, Alexa, there's obtaining a renewal supply of high quality orthopedic equipment, like imaging, tools, and implants to practice state-of-art trauma care. Means without achieving this goal, the fellowship will not be successful. State-of-art trauma care requires state-of-the-art equipment and implants. And here the hospital has to learn how to acquire implants and how to keep the stock. And the next slide is to enable patients to access appropriate treatment, because so that instead of to have good surgeon and good hospital, we still have this problem with patient, and by having partners which accompany us by contributing for the success of this program, like it has been in other epidemic programs, where medical treatment are given free of charge or at certain low fees for patients to access the care needed. And in conclusion, this is a collaborative program between the KUMC and African Trauma Medical School and the Mission Hospital, which Mission Hospital actually they do most of the job of establishing hospital there, especially in a rural area, through ATI, in which we hope will improve and develop the healthcare system in many African nations to treat trauma, reduce substantially the large burden of injury and trauma-related disability and death. Also, since we are working with academic departments that train surgeons in Africa, this same model can serve as a mirror in many African countries where similar training can be done either locally or regionally after acquiring appropriate training, trauma center, and skillful trauma surgeons, which are former fellows who can train others and by this fill up the gap of disparity. And lastly, knowing that the approach to improve healthcare system in this part of Africa, it's usually very complex. That is depend country to country and require accurate data study, acceptance from people on the site of action, and teamwork, and being aware that KUMC has now introduced global health training. It's going to be very advantageous for us to get involved in this program, the global health training, as part of our curriculum to efficiently improve our efforts as leaders. I think that's all. Next slide is just showing my team in Lusaka. And thank you for your attention.